So I wanted to do a video on inotropes and vasopressors. I realized that I did a video on dopamine and people understood the concept. So I thought I would go on and piggyback off that video and have a look at inotropes and vasopressors. Grab a piece of paper and let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we look at medical topics in depth. Today we're going to be looking at common inotropes and vasopressors, with the main focus of this video looking at Dobutamine as well as epinephrine, and we'll look at just a bit about dopamine. But I did do a video on dopamine. I will leave it tagged at the end of this video. I'll also leave it tagged in the description below so you can go check it out and watch that video if you don't understand the calculations that I'm going to do in this particular video. Grab a piece of paper, let's go. Remember that you're going to be using these inotropes and these vasopressors very commonly in the emergency department, very commonly in ICU. They're going to be used to maintain blood pressure in patients that are in shock. They're going to be used for the purpose of resuscitation. They're going to be used for patients that become hypotensive, for example, those that have sepsis. So these are drugs that are going to be increasing the cardiac contractility. So anything that will increase the cardiac contractility is referred to as an inotrope. Then they may also cause some vasocompression or vasoconstriction. We call those as vasopressors. So positive ionotropy is just increase in contractility of the heart. Positive chronotropy is increase in heart rate. Then the vasopressor effect is, of course, the vasoconstriction. Remember, these drugs are going to be used in patients that have shock. Whenever you have tried your IV fluids and they are not working or they are inappropriate, for example, patients with cardiogenic shock, they don't need so much IV fluids. You would rather give them some inotrope and vasopressor support. Most of these are going to be delivered through an infusion line, though it's actually quite important that you should have a central line, especially if you're going to be infusing high doses of these inotropes and vasopressors, because some of them have the potential to cause some peripheral necrosis. So you want to give them in a central line, except for some that can be actually given in a peripheral line. So many of these commonly used agents are going to be just the synthetic versions of the endogenous catecholamines, because remember, most of these are going to be produced in the body. So before you continue the use of inotropes or even vasopressors, before you even start them, make sure that you correct any underlying cause that is correctable. If there is some hemorrhage, address that, stop the hemorrhage. If there is sepsis, remove the focus of infection, treat them with antibiotics. Or if there's myocardial insufficiency, address that first. Remember that hypotension must be treated promptly because it's going to be preventing your patients from becoming hypoxic. It's going to be preventing your patients from undergoing end organ damage and, of course, organ failure. There is some volume replacement that is needed. And remember that this is very important, especially for patients that are hypovolemic, to replace this volume, and even in patients that have hemorrhage and even in patients that have sepsis. But remember, fluids are going to be detrimental for patients that have cardiogenic shock. The choice of the inotrope or the vasopressor that you're going to use generally is going to depend on your hemodynamic status. It's going to depend on your underlying pathology. For example, if you're dealing with septic shock, for example, your drug of choice would be your Dobutamine, your norepinephrine or your epinephrine. If this patient is in shock, that's the first line. Way back, it used to be dopamine, but we no longer consider it as dopamine. I did do a video on the sepsis as well as septic shock. I'll leave it tagged at the end of this particular video. You can head over and watch that video as well. So remember that cardiac output can be improved by use of sympathomimetic inotropes like adrenaline, which is also referred to as epinephrine, dobutamine, as well as dopamine. And in patients that have septic shock, remember, fluid replacement and inotropic support sometimes can fail to maintain the BP. So you're going to give a vasoconstrictor like noradrenaline or norepinephrine or even epinephrine infusion to maintain the BPs in these patients with septic shock. Those that have cardiogenic shock usually have peripheral resistance, which is quite high. So you want to raise it, and raising it further, rather, is going to actually cause a worsening of the myocardial performance, because you remember that blood pressure is a product of cardiac output times total peripheral resistance. And if your peripheral resistance is already high in patients with cardiogenic shock, if you give them a vasopressor, it may be detrimental to them. So therefore, you want to give them a drug like dobutamine, which to some extent also causes relaxation of those peripheral vessels and reduces the systemic vascular resistance, therefore reducing the work on the heart. So for example, in patients that have cardiogenic shock due to, for example, decompensated heart failure, you're going to be putting them on a dobutamine. So remember also that the use of sympathomimetic inotropes as well as vasopressors should be confined to the intensive care setting, to the emergency department, and you shouldn't use this on a general ward because they have risk of a lot of side effects if they're mishandled, and most of these, if not all of them, are going to require an infusion pump that you may not sometimes necessarily find on your wards. But of course, if you're trapped somewhere in the bush or in a low facility place, you have no choice but to use them. I'll show you how you can use them, because you're going to also want to perform some invasive hemodynamic monitoring. So the commonly used drugs that I'm going to discuss in this particular lecture are going to include adrenaline, which is present, or epinephrine, dobutamine, dopamine, just in brief, but I did an in-depth discussion about dopamine at the previous video, so I do leave that tagged in the description. I'll also leave it tagged at the end of this particular video. So remember that you need a central venous access for administration of these vasoactive agents. And recent studies have shown that both dopamine, norepinephrine, and even phenylephrine at higher doses can actually even be safely administered via peripheral venous access. But for most of them, especially if you're giving them for a very long time, please make sure that you get a central venous line. We'll begin with the first inotrope, which is dobutamine, or dopamine, as shown in this picture here. So remember, this one here is a cardiac stimulant. It's going to be having a quite strong inotropic effect, and it will have a weak chronotropic effect. It somewhat also does affect the contractility of the vessels. So it has effects by binding and stimulating the beta-1 receptor. Remember, beta-1 receptors are found on the cardiac muscle. So once these are stimulated, they'll cause this cross-bridge cycling of the myofilaments, and they'll cause the heart to contract even harder, with very little effect on the heart rate. So remember that it's going to increase the contractility, and remember, if the heart is contracting more, this means that it's pushing out more blood. So the end systolic volume is going to be reduced, and therefore your stroke volume is going to be increased. And remember that cardiac output is a product of stroke volume times the heart rate. There's very little effect on the heart rate, but your stroke volume has increased. So this is going to increase the cardiac output, and in turn, this is going to increase the blood pressure. There may be some changes in the cardiac output, but then remember that the body sort of adapts to whatever is happening. So it's going to trigger this baroreceptor mediated response, and this is going to cause a decrease in the systemic vascular resistance without causing any little effect on the arterial blood pressure. So that's why I say that in those patients that have cardiogenic shock because of acute decompensated heart failure, especially if they have high peripheral resistance, dobutamine will be a very good drug, because it will cause this peripheral vasodilatation, reducing the workload on the heart, and therefore not even affecting the BP or dropping the BP to significant effects. It also has some beta-2 activity, which contributes also to the reduction in the systemic vascular resistance, as well as some alpha-1 activity to a lesser extent, which contributes to some vasoconstrictory effects, but these are usually negated by your baroreceptor reflexes as well as the beta-2 activity of the drug. So remember, this medication is often indicated for patients with decompensated congestive heart failure because of the sympathomimetic effects that it has. And despite it having these improvement in hemodynamic status, remember that dobutamine does not significantly improve the mortality outcomes of patients that have heart failure, either those that are admitted in the hospital or those that are in the outpatient. Indications and contraindications, remember that it's going to be used in patients that require inotropic support, in infarction, in those that have cardiac surgery, in those with cardiomyopathies, during positive end expiratory pressure ventilation, in patients that have septic shock, in those that have cardiogenic shock, but though this is an off-label use according to the FDA, and usually we use this as a bridge for patients that are yet to actually undergo coronary revascularization, or patients that are undergoing mechanical circulatory support or heart transplant, to keep their BPs and to maintain their BPs at safe levels. You can use it in patients with severe systolic dysfunction, those that have low blood pressure and have significantly reduced cardiac output. We use it to maintain systemic blood flow and to protect against end organ damage. We use it also in the long term for palliative care, especially for patients that have late stage heart failure, stage D, and these ones who are not really candidate for those surgical interventions, like things like mechanical circulatory support, or those that require cardiac transplant. Maybe they're too frail to go to the operation or to go to theater, then we can use it for symptomatic control regardless of the guideline directed medical therapy. We can also use it in stress testing, cardiac stress testing, what we do in what is known as a stress ECG. And if a patient cannot perform an exercise stress test, then we can use dobutamine. It's contraindicated in patients that have a pheochromocytoma. A bit about the pharmacokinetics. Remember that the onset of action is about 1 to 2 minutes after administration, and it will take its maximum effects up to 10 minutes. The plasma half-life is roughly around 2 minutes, and it's going to be metabolized in the tissues, and it's going to be metabolized in the liver through a catechol methylation as well as conjugation, and it will be excreted in the urine as conjugates of dobutamine as well as 3-O-methyl-dobutamine. Now, what's our dose? So 2.5 to 10 micrograms per kg per minute. Keep this in mind. Generally, you can start off from 0.5. You can even reach as far as 40 micrograms per kg. But usually in our emergency department, your doses will range between 5 to 20 micrograms per kg per minute. If you have given these inotropes and they are adequate, you have titrated them to the maximum dose and still your patient is not improving, suspect some other diagnosis. Maybe your patient has a pulmonary embolism. Maybe your patient has a cardiac tamponade. Maybe your patient has a pneumothorax. So remember that your dobutamine dosage for cardiac decompensation and heart failure starts off with low dose, about 0.5 to 1 microgram per kg per minute, and you increase to a maximum of 40 micrograms per kg per minute. Keep these doses in mind because they'll help you with the calculation. Remember, before you administer the drug, if it's a parenteral drug, you should actually visually inspect it for any particulate matter, any discoloration, and as long as the solution and the container allow for this inspection before you actually administer the drug. Do not also forget to check the expiry date. Now, what formulation do we have? So there are many different formulations that you could get, and the concept is the same for all drugs. I always tell my students at the ward that the concept for all the drugs is actually the same. So when you read the packaging of each drug, they'll give you a concentration on it. They'll say each mil contains such and such milligrams of the drug. So in terms of dopamine, you could have one that comes at each mil containing 5 milligram. And if you have a 50 ml of that solution, it means that 5 multiplied by 50, which is 250. So if you give 5 mils of that entire vial, you have given 250 milligrams of dobutamine. Remember, mg in this case is going to be milligrams. Sometimes you may see mcg, which is micrograms. Micrograms are much smaller than milligrams. Then in terms of the other formulation, it could come as a 12.5 milligram per mil. So each mil consists of 12.5 milligrams of dobutamine. So this comes as a 20 ml solution. This is the one that's quite common on the ward, but you should check whatever your hospital buys. So this one still again is also going to consist of a total of 250 milligrams of dobutamine. So remember that the injection should be diluted before you give it, or if given undiluted, with a syringe pump, and it's compatible with 5% dextrose, normal saline, and you dilute it to a concentration of 0.5 to 1 milligram per mil, and you give it via an infusion pump. So if you give higher concentrations, a maximum of 5 milligrams per mil, you have to give it through a central venous line. Now, how do we create this infusion? Because this is where a lot of commotion and a lot of havoc is. And this is where I want you to pay the most attention and to pay the closest attention. So there are 6 steps that I want you to learn, very easy steps to follow. So step 1 is you first want to know which concentration of dobutamine you have available. Step 2 is you want to create the desired infusion solution. Step 3, you want to calculate the dose that is required. Step 4, you want to calculate the infusion rate in mils per hour, because you're going to enter this infusion rate into your infusion pump. Then step 5 is to escalate the rate. If there is no response, then step 6 is to wean off the patient when indicated, when the patient is stabilized. So we'll begin with step 1 in terms of dobutamine. So like I said, you have 2 available solutions, 5 milligrams per mil in a 50 ml solution, 12.4 milligram per mil in a 20 ml solution. So whichever one you have, each of these are going to be consisting of 250 milligrams. So that's the first thing. You know the concentration that you have of the solution. The next thing is you want to create a solution of your desired concentration. You want to create an infusion solution. One thing that you want to do is you don't want to infuse a lot of volume into this particular patient, especially with inotropes, because moreover, you've given this patient some IV fluids. You don't want to keep adding even more IV fluids. You tip them into heart failure by increasing their by increasing their end diastolic volume and increasing their preload. So we're going to create a solution that has a concentration of 1,250 micrograms per mil, which is equivalent to 1.25 milligrams per mil. You can choose one unit to be working with through and through. I find it easier to be working with the milligrams per mil rather than the micrograms per mil, but whatever works for you. As long as you do the math correctly and all the units are being multiplied or divided correctly, never divide two different units. For example, if you have micrograms per mil, don't divide with a milligrams per mil. You convert to one unit. So how do you make this solution? There are two options depending on whatever you have. So if you have the solution that comes as 5 milligrams per mil in a 50 mil solution, what you're simply going to do is you want to end up placing 250 milligrams of the dobutamine in 200 mils of saline. It's not as easy as I'm saying it right now, because most people would think, let's just get 250 milligrams of dobutamine and we add it to 200 mils of saline. That's not what you do, because you have to first remove an equal volume of the fluid that you're adding so that you don't increase the total volume that you have of the final solution. So what do I mean? This solution that has 250 in it is 50 mils. So what are you going to do so that you actually end up with a 200 mil solution of fluid? So the first step is you want to first get 200 mils of normal saline. Then from that 200 mils of normal saline, you can remove 50 mils of it. So you'll be remaining with 150 mils of normal saline. Or if you don't want to even remember this, just give the nurse the instruction that get 150 mils of normal saline, then you add 50 mils of this solution of dopamine in this concentration, 5 milligram per mil. So it means that the total concentration that you have created is going to be 200 mils of solution, and in this 200 mils you're going to be having 250 milligrams of dopamine. And if you do the divisions, it comes down to this concentration, 1.25 milligrams per mil. The second option, if you have the solution that has the 20 mil solution, 12.4 milligrams per mil. So what you're going to do again is you remove 20 mils from the 200, then you add the 20 mils of this dopamine in this concentration to make up 200 mils that consist of 250 milligrams of dobutamine. So in essence, you can also give the nurse instructions, say get 180 mils of the normal saline, then add 20 mils of this solution of dobutamine, 12.4 milligrams per mil solution, and to make up the entire solution as 200 mils. I hope that makes sense. So you have now created a solution that has 200 mils and it's going to be containing 250 milligrams of dobutamine. So it's in a concentration of 1.25 milligrams per mil. Then step 3 is you want to calculate the dose required. Remember, our dose is going to be ranging from 2.5 to 20 micrograms per kg per minute. Our usual dose is 5 to 20 micrograms per kg per minute, but it can reach up to 40 micrograms per kg per minute. So I'll give you an example. So if you have a 60 kg man, for example, that is requiring a dopamine infusion that is going to start at a rate of 2.5 micrograms per kg per minute, we're going to say his weight, which is 60, multiplied by 2.5. You get 150 micrograms per minute. But remember, I told you that I like to work with milligrams. So if you want to change this micrograms to milligrams, you simply divide this answer by 1,000. So if you divide this by 1,000, you get 0.15 milligrams per minute. This is how much this patient needs per minute. So that's step 3. Then step 4 is you now want to calculate your infusion rate. How many mils per hour you're going to give this patient, because you want to enter this information on your infusion pump. So again, we have our 60 kg man that requires a dobutamine infusion starting at 2.5 micrograms per kg per minute. And the dose that we're using, we've calculated at 0.15 milligrams per minute. I've forget about the micrograms. I want to use milligrams because it's easier when you do the calculations in milligrams per minute. So remember, if they are receiving 0.15 milligrams in 1 minute, how much will they receive in 1 hour? You multiply that by 60 because there are 60 minutes in an hour. So 0.15 by 60, so they should receive 9 milligrams in 1 hour. Remember, what we're aiming to calculate is how many mils per hour are we supposed to receive. So in 1 hour, this patient must receive 9 milligrams. But remember, our solution that we have created was 1 mil gives us 1.25 milligrams. So how many mils do we need to make 9 milligrams? So 1 mil is equals to 1.25. 9 milligrams is equals to x. So x multiplied by 1.25, 9 multiplied by 1, then you divide both sides by 1.25. This is simple math. If you've made it to medicine in this particular stage, I don't think you should have problems with this. So 9 multiplied by 1 divided by 1.25, it gives us 7.2 mils. So for this person to receive 9 milligrams of the drug, you give 7.2 mils. But remember that they're receiving this 9 milligrams over an hour. So it means that this 7.2 milligrams or this 7.2 mils should be given over the hour. So that's the infusion rate that we have calculated. This patient needs to receive 7.2 mils per hour. So you're going to enter the information into the infusion pump. The volume to be infused is 200 mils. Your rate is 7.2 mils per hour. That's it. And then the infusion pump will calculate the time in which your infusion is going to finish. So if you don't have an infusion pump, you may sometimes calculate how many drops per minute and be counting the drops from the giving set. This here is not really advised because it's not so accurate, and you may sometimes be giving the patient less than they require or more than they require. So generally, it's better if you actually even use the pediatric giving sets, which are known as a micro drip, the ones you find in the pediatric neonatal intensive care unit, the NICU. So those ones can give you 60 drops per mil. That's the drop factor that they can give you. The ones that you get in the adult ward are either 15 drops per mil or 20 drops per mil. So the ones that are 60 drops per mil are known as micro drip giving sets. We want to use those as opposed to the macro drop giving sets because the infusion rates that we have calculated are very low. So how do we calculate the drops per minute? We'll say the volume that's going to be infused in mils divided by the time in minutes multiplied by the drop factor. Remember, we need to give 7.4 mils per hour. Is it 7.4 or 7.2? Actually, 7.2. So assuming that we give the infusion over 4 hours, it means that this is actually supposed to be 7.2. Let me just correct this here. Or we could just delete it completely. We'll delete this completely from here. So we need to give 7.2 mils in 1 hour. So 7.2 divided by 60, that's the time in minutes. Then afterwards, we multiply that by the drop rate, which is 60. So in essence, we should give 7.2 drops per minute. So you're going to be roughly around 7 drops per minute that you set your infusion pump, rather your giving set at. So you actually count and you should have about 7 drops in a minute. Then step 5 is to escalate if the infusion, if there's no response. So remember, the infusion rate is adjusted at short intervals, considering the patient's response. Remember, these drugs work very fast. Within about 10 minutes, they should take some maximum effect. So usually adjustment is at a minimum of about every 15 minutes. So the factors that you're going to be putting into play, things like your systemic blood pressure, your frequency of ectopic activity, your heart rate, urine flow, and whenever possible, central venous pressure measurements, your cardiac output, or your pulmonary capillary wedge pressure. These are going to be used to titrate how much you're going to be giving. But generally, optimal infusion rates vary between patients, but typically are going to range between 2 to 20 micrograms per kg per minute. They may be slightly below this range. In some rare instances, you may go even as high as 40 micrograms per kg per minute. Remember, when you're doing your stress echo or your stress ECG or your stress nuclear test, you initiate at 5 micrograms per kg per minute, then you increase at intervals of 10 micrograms per kg per minute every 3 to 5 minutes until you reach your target heart rate that is needed. If your patients become stable, your BPs are holding, then you can actually begin to wean off the patient consistently. So you wean off by 1 microgram per kg per minute as quickly as every hour, provided the patient doesn't have any symptoms or they do not become hypotensive, their MAP doesn't drop. Then if it does, then you have to revert to their previous dose. So here's an exercise that I want you to comment in the section below. I will pin the comment that gets the answer right first as the pinned comment. So you have a 76 kg man with cardiogenic shock requiring Dobutamine infusion at a dose of 7.5 micrograms per kg per minute. Calculate the infusion rate in mils per hour, assuming 250 milligrams of dobutamine is in 200 mils of normal saline. So comment your answer in the section below. I will leave the pinned comment of the correct answer. So remember that dobutamine is incompatible with bicarbonate or other strong alkaline solutions, and tolerance actually develops with continuous infusions longer than 72 hours. So it should be used in caution with patients that have acute heart failure, those with acute myocardial infarction, those with arrhythmias, those with diabetic mellitus, those that have marked obstruction to the cardiac ejections, for example, idiopathic hypertrophic subaortic stenosis. Extreme caution should actually be taken when you're using it in this condition. Patients with hyperthyroidism, ischemic heart disease, occlusive vascular disease, severe hypotension, susceptibility to ankle closure glaucoma, tachycardia, elderly, because elderly patients tend to be quite sensitive to these vasopressors and inotropes. And remember, extravasation can actually cause tissue necrosis. You keep a patient on high doses of these drugs, you'll find their digits have become black, and they may actually have some necrosis, especially if it's being administered via a peripheral vein. And remember, if it's a peripheral vein, make sure it's in the cubital fossa, not those peripheral veins that you see in the hands. So you require monitoring of serum potassium concentration. Side effects that are rare: psychosis. Those that are very rare, you may develop ankle closure glaucoma, AV blockage, bradycardia, cardiac arrest, coronary artery spasms, hypokalemia, myocardial infarction, petechial bleeding, and those that the frequency is not often known or they haven't been reported as much but have been seen are things like anxiety, arrhythmias, bronchospasms, cerebral hemorrhage, chest pain, dyspnea, eosinophilia, fever, headache, hypertension. This is marked increase in the systolic blood pressure. This is going to indicate that there's some sort of overdose. Hypotension, increase in urinary urgency, myoclonic spasms, nausea, palpitations, paresthesia, phlebitis, pruritus of the scalp, pulmonary edema, rash, reduced platelet aggregation on prolonged use, tachycardia, tremors, as well as vomiting. Here's a table that's quite high yield. You can get a screenshot of it. It will help you actually calculate the different doses that are needed for patients that are on the dobutamine infusion. So you can take a screenshot of it. The next that we'll move on to is adrenaline or epinephrine. So remember, epinephrine is going to be working on all the adrenergic receptors. At low doses, it works primarily on the beta 1 to increase the contractility of the heart as well as to increase the heart rate. So it has a positive inotropic as well as chronotropic effect. The beta 2's effect is it's going to be working on the airways and even vasodilatation. And at higher doses, for example, patients that have had cardiac arrest, it has an alpha 1 effect causing vasoconstriction. So it's used in acute hypotension associated with septic shock, is one of the first line drugs in septic shock patients. Anaphylaxis, cardiac arrest, symptomatic bradycardia that's unresponsive to atropine and unresponsive to pacing, asthma exacerbation, mydriasis. It comes in two main formulations, one in 10,000 and one in 1,000. So what do I mean? In 1 ml of the solution, you have 10,000 micrograms. So that's in essence 0.1 milligrams per mil. Then in 1 ml of solution, you have 1,000 micrograms. So that is roughly 1 milligram per mil. So you can have a 0.1 milligram per mil solution, which is a slightly low dose. This is the one that we often use for patients that have arrested. And then 1 milligram per mil is the one that we use when we're making the solution. So what's our dose? 0.05 to 1 microgram per kg per minute. If we are using it in septic shock, our recommended dose is 0.05 to 2 micrograms per kg per minute. An IV infusion then that you titrate according to your MAP, and you make sure that your MAP is above 65. Remember, you adjust the dose every 10 to 15 minutes by about 0.05 micrograms to 0.2 micrograms per kg per minute to achieve your desired blood pressure goals. After hemodynamic stabilization, you begin to wean them off every 30 minutes over 12 to 24 hours. It's compatible with D5W, D10W, dextro ringers, dextrosaline, normal saline, lactatase ringers, ringers lactate. And to prepare this infusion, remember you're going to dilute epinephrine in the compatible solution. Generally, we want to avoid giving it, especially with normal saline. It's not really recommended. For those that have cardiac arrest, we just take 1 milligram of the 1 in 10,000 mils. That's 0.1 milligram per mil, and we give this every 3 to 5 minutes as required as part of resuscitation protocols. So again, remember that Step 1 is you want to know which concentration of epinephrine you have available. Step 2, you want to create the desired infusion solution. Step 3, you want to calculate the dose required. Step 4, you want to calculate the infusion rate in mils per hour. Step 5, you want to escalate the rate if there's no response. And step 6, you want to wean them off when indicated. Remember that step 1, our usual epinephrine dose that we use is 1 milligram per mil. That's what we're going to be using. Step 2, when we're creating the solution, we want to aim to create a solution that has 60 micrograms per mil. So in essence, that's about 0.06 milligrams per mil. So we're going to get 12 mils of the epinephrine solution. We're going to get 12 mils of the 1 milligram per mil epinephrine solution, and we add it to 188 mils of compatible solution, so that you make up a whole solution that has 200 mils, which contains 12 milligrams of epinephrine. And when you do the divisions, it comes down to your 0.06 milligrams per mil. So that's how you make our concentration. So how do we now calculate the required dose? Example, if we have a 70 kg man in septic shock with hypotension requiring epinephrine infusion, our initial dose of 0.05 micrograms per kg per minute. So our total dose is going to be 0.05 multiplied by 70. That gives us 3.5 micrograms per minute. Remember, this total dose must be given per hour. So if we want to give it per hour, we multiply that by 60. So it gives us roughly around 210 micrograms per hour, which is about 0.21 milligrams per hour. So to calculate the infusion rate in mils per hour, remember our 70 kg old man needs 0.21 milligrams per hour, and our concentration is 0.06 milligrams per mil. So 1 mil gives us 0.06, so X will give us 0.21. So X multiplied by 0.06, 0.21 multiplied by 1. Then when you do the math, it gives us 3.5 mils per hour. So you're going to set the infusion rate at 3.5 mils per hour. So if you want to find the drops per minute, this is strictly not recommended for this. Your volume to be infused divided by the time multiplied by the drop factor. So you give about 3.5 drops per minute. So about 3 to 4 drops per minute. This is not recommended, by the way. How you escalate, so we adjust the dose every 10 to 15 minutes by 0.05 to 0.2 micrograms per kg per minute to achieve our desired blood pressure goals. When patient is stabilized, after hemodynamic stabilization, we can wean off the patient every 30 minutes over 12 to 24 hours. Here's our exercise 2. So leave both your answers in the comment section below. I will leave a pinned comment of the answer that gets it correct first as the pinned comment on this video. So a 57 kg man requiring adrenaline infusion for septic shock at a dose of 0.1 micrograms per kg per minute. Calculate the infusion rate in mils per hour, assuming 12 milligrams of adrenaline is in 200 mils of D5W. If you get this correct and you get these exercises correct, then you have gotten the concept. Yes, you're good to go. You're ready to see your patients on the ward. So what are some of the pharmacokinetics? Remember that it's going to be administered parenterally. Epinephrine has a rapid onset and a short duration of action. So when it's given IV, it has a half-life of fewer than 5 minutes. It's very quick. Metabolism is primarily in the liver, along with the various other locations like the kidneys, the skeletal muscles, and even mesenteric organs. And generally, it's going to be degraded into these inactive metabolites, which are namely vanillin-mandelic acid by the enzymes MAO as well as COMT, the catechol O-methyltransferase, as well as the monoamine oxidase enzymes. So these are going to be excreted in the urine, but small amounts of the drug can actually be excreted and changed in the urine. Side effects include peripheral administration that can lead to extravasation, and it can cause tissue necrosis via the vasoconstriction. So short-term delivery can be given in a large proximal peripheral vein, for example, that in the cubital fossa. Then ischemia can happen especially to the GIT, to the kidneys, to the extremities. It can result in atrial as well as ventricular arrhythmias. So in case that you have some extravasation of this epinephrine, remember that your antidote is going to be your phentolamine. So you're going to prevent this by infiltrating the area with about 10 to 15 mils of saline, and this should contain about 5 to 10 milligrams of phentolamine, which is an alpha-adrenergic blocking agent. Here again is another high-yield table that I want you to get a screenshot of and write it down, store it wherever you want. It's going to help you with the calculations. Last section of this video, like I said, I already did a video on dopamine, so I won't go into much details of this. So remember, it's a cardiac stimulant that works on the beta-1 receptors, predominantly on the cardiac muscle, and it increases contractility with very little effect on the heart rate. It's used in cardiogenic shock, in infarction, or even in cardiac surgery. The initial dose is 2.5 micrograms per kg per minute, and it comes in a formulation of 40 milligrams per mil, which is about a 5 ml solution. So it comes as 200 milligrams of the dopamine, and this is the one that we have common in our setting. You can also have the 160 milligrams per mil. So this comes as a 5 ml solution, which contains 800 milligrams of the infusion. So often we dilute it in the D5 or the normal saline to a concentration maximum. We shouldn't exceed 3.2 milligram per mil. Of course, I discussed this in great detail when I looked at the dopamine video, so I'll leave that tagged at the end of this particular video. So it's not compatible with bicarbonate. So you should check out the video on dopamine calculations. I'll leave it tagged at the end of this video as well as in the description below. I really hope you enjoyed this video on the inotropes and vasopressors. If you did, consider subscribing to the channel, hit the bell notification icon. It's been 3 years since we started doing this. 3 years ago, we were at 100 subscribers. Now we are at 19,460 subscribers. And today is, of course, my birthday. So show some love, drop a like, drop a comment. To Zambia and beyond, my name is Dr. Moses Kazevu. Until next time, bye-bye.